Welcome everyone, good morning. Thanks for coming to Grand Rounds today. I'll turn it over to Ali to introduce our speaker.
Hello everyone, good morning and welcome to this edition of our virtual Grand Rounds. We're thrilled to be hearing from Dr. Percio Gulko today. Dr. Gulko earned his medical degree and completed training in internal medicine and rheumatology at the Universidade Federal do Rio Grande do Sul in Brazil. He came to the United States as a research fellow in rheumatology at the University of Alabama in Birmingham, and followed this with residency training in internal medicine at the Medical College of Georgia, followed by rheumatology fellowship at the National Institutes of Health. He then held a faculty position at Columbia University prior to joining the Feinstein Institute for Medical Research at Northwell, where he served as a professor of medicine and director of the Laboratory Experimental Rheumatology prior to joining Mount Sinai. Here at Mount Sinai, Dr. Gulko serves as the Lillian and Henry Stratton Professor of Medicine and as the Chief of the Division of Rheumatology. He has received numerous grants from the NIH as an investigator and is widely published in leading peer-reviewed journals. He's a frequent lecturer to both national and international audiences and serves on the editorial boards of the journals Genes and Immunity and Physiological Genomics. A very warm welcome this morning to Dr. Percio Gulko.
Thank you, Mustafa. Thank you for the nice introduction. And thank you for inviting me to speak here today on Medicine Grand Rounds. So I'm going to be presenting today data that, as I think about, should have probably been presented by Dr. Lara Joni, who is actually attending the talk, who did most of the work that I'm going to be sharing with you today. And we wanted to share with you our new discoveries about the role of magnesium in arthritis and the development of Treg cells. Just move to the next slide. Okay. So disclosures, nothing relevant for this talk today, and objectives. So hopefully at the end you understand potential role for magnesium in arthritis and in the development of FOXP3 cells. So what is rheumatoid arthritis? So I'm not going to go into a lot of detail of how we're managing and treating and pathogenesis, but I certainly want you guys to understand that rheumatoid arthritis is a symmetric and chronic form of autoimmune and erosive disease that can start as a mild arthritis with swelling and tenderness on small joints of the hands, the MCPs, the PIPs, the wrists, evolving early on to some deformities related to laxity of tendons and ligaments, and in advanced stages can lead to major deformities and disability. Fortunately, we rarely see this anymore, and when we see are typically patients that have decades of disease that pre-exist the biologics. But now with more awareness about disease, new therapeutic options, we just don't see this anymore, fortunately. And here, just to give you a sense of when we talk about erosions, what are we actually talking about in RA? So here's a normal hand, and here's an RA hand, and you can see that there's here you can see joint spaces, right? Well, here they're gone. And when they're gone, that means that the cartilage that represents the space is gone. So that represents cartilage erosion, right? And also, bone erosion, so those lucencies that you see here. And that also goes with periarticular osteopenia related to a number of cytokines, osteoclast activation, and reduced mobility. And obviously, all those deformities that can be missed. And so you can see this in an X-ray, like those lucencies on the joint. There was supposed to be a wrist here, is all eroded out, right? So see the wrist joint here, disappearing here, gone here. And this is related to synovial hyperplasia and inflammation around those bones and joints that ultimately invades and destroys that cartilage. That erosion is characterized by synovial hyperplasia and this highly invasive synovial tissue that, for example, in a normal individual, if the arrow here, the pointer is marking the synovial cavity, this would be the lining layer of the synovial tissue, and this would be like the sublining. So typically the lining has 3 to 5 layers of synovial fibroblasts intercalated with macrophages. In rheumatoid arthritis, you see this pronounced synovial hyperplasia with dozens of layers, number of new vessels, no angiogenesis, and this massive infiltration with lymphocytes, plasma cells, macrophages. So these are rat joints, but just to give you a sense that that hyperplastic synovial tissue then invades and destroys bone and cartilage, right? So this is bone, here's cartilage. While in protected animal strains that I'll be telling you about, any normal joints, right? You have this preserved cartilage, the bone, and there's this a thin synovial membrane that surrounds the joint. There's a number of non-genetic environmental risk factors in RA that we're just beginning to understand. The most strongly and reproducibly, I would say, shown is really smoking. Smoking increases the risk to develop arthritis by twofold or greater. But there are other occupational exposures like exposure to noxious airborne agents, exposure to mineral oils. Low vitamin D levels have been associated with more severe disease in rheumatoid arthritis. This is an interesting one. Sugar sweetened soda consumption was a large epidemiologic study. It hasn't been confirmed yet, but it's a very well done study showing that sugar sweetened sodas increase risk. So again, nothing good about sugar sweetened sodas, and one more reason to not drink them. I hope that's not what David is drinking right now. And then also recently epigenetic modifications that have been described, and we were involved in describing epigenetic modifications in synovial fibroblasts. And the microbiome that we're just beginning to understand and trying to also find ways to modulate to hopefully help control disease, not only rheumatoid arthritis, but a number of autoimmune diseases, inflammatory diseases, IBD, cancers, and other conditions. In RA, there has been a highly reproducible, I would say, increased prevalence of Prevotella copri in feces of patients with RA. And that's been strongly identified early on, but also in late stage. And this has been shown in different populations in the United States, in Japan, in Germany. The lung, I don't think has been explored yet, but it's interesting that in recent onset, in early onset RA, it have been described to have up to 40% of the patients may have kind of high resolution CT changes, even in asymptomatic patients. And there's a lot of citrullination in the lung, and RA patients do produce anti-CCP antibodies in over 90% of the patients. So there is this interesting, intriguing link that what is the role of the lung in early disease that just has not been explored. And also P. gingivalis, the presence of P. gingivalis in the mouth has been associated with increased risk. There's a number of genetic factors regulating both susceptibility and severity. I talked a little bit about this in our work when I gave grand rounds, I think maybe 5 years ago. We'll not go into that today. But really, there is little that we know about the genes that regulate disease severity. And I would say that so far, while we have, there's a number of susceptibility genes that have been identified that has not yet translated into actionable targets or actionable biomarkers to predict response or disease outcomes. It's undeniable that in the past, since 1999, when etanercept was FDA approved to treat rheumatoid arthritis, that has been this really fantastic development in therapy. And we now have a whole arsenal of options to treat rheumatoid arthritis, and disease outcomes have improved significantly, and so have survival of patients with rheumatoid arthritis. But when you actually look at it's better now than it was before, but when you actually look at the numbers, if you were a patient, you would expect to be like at least 70% better than you were before to be able to live a nearly normal life, I would say. Ideally, you would like to be in remission, right? Remission remains uncommon, especially sustained remission. Remission may be achieved, but sustained remission remains it really is like less than 10 to 15%. And when you look at biologic-induced improvement of 70% in disease activity, most of the trials show that you seem to achieve that in around like 20% of the patients. So I would say it's suboptimal, and there is room for improvement. But basically all the biologics available now and the JAK inhibitors seem to achieve similar levels of improvement of like a 70% improvement or a 20% improvement or a 50% improvement and rates of remission, right? So what do we need? What are the unmet needs? So this is a question, since this is our rheumatology, this is like medicine grand rounds, right? It's important to keep in mind. So when you're doing research, what are the issues that you're trying to address? Like what drives us? What are the unmet needs in the disease we are studying? So in RA, the key issue is that while we have a number of treatments, remission remains uncommon. Like I was saying earlier, remission, 60 to 70% of the RA patients in trials only achieve a 20% improvement, and that applies to both biologics and JAK inhibitors. The other issue is that while a percentage of patients achieves remission and great response to agent A, B, or C, right now we don't have a good way of predicting who will respond to each individual treatment. So basically we follow established guidelines based on level of comfort and experience with the different agents. And it would be nice if there was a biomarker, genetic or not, that would tell us that this patient is likely to achieve remission with drug A versus not achieving remission with drug B, right? And all those treatments, the best of our treatments have been associated with increased risk for infections. And while in cancer, combination therapy with different agents or powerful agents has been used, that has been tried in rheumatoid arthritis, and there was an early study in 2003 that showed that the combination of TNF inhibitors and IL-1 RA, IL-1 inhibitor, was attempted. That was highly toxic, and the study was interrupted. And there has not been any additional attempts to combine immunosuppressant agents at this level. So my reading of the literature is that it seems that all the biologic and JAK inhibitors achieve similar rates of response, suggesting that there is a maximum plateau that we can achieve with simply targeting the immune system. And beyond that, there seems to be, we don't achieve significantly better results, but increased toxicity. So if you think like this response rates, right, versus the different treatments, let's say that each color here is a biologic or a JAK inhibitor. Let's say that 50% of the patients will achieve a decent response, not remission. Ideally, we would like to achieve like 100% remission, right? So how do we close this gap, right, from moderate control to really complete disease control? So that is, I would say, the key question here. And so far, it appears to me that that's not going to be achieved or has not been achieved with simply targeting the immune system. So my laboratory has been putting a lot of emphasis into looking for alternative options to build upon the benefits that we have already achieved with the biologics and JAK inhibitors. And we have identified synovial fibroblast specific targets and therapies that target the synovial fibroblast to in an attempt to ameliorate disease and improve disease control. And that's just beginning to be explored. So just an overview of what we're trying to do is really using a combined strategy over the years with focus on disease severity and joint damage, with a major emphasis in the synovial fibroblast. And we're actually beginning now to do ultrasound-guided synovial biopsies to study earlier disease. And Dr. Wiesendanger and Dr. Chi, who may be here in the talk, are leading this effort to do synovial biopsies here at Mount Sinai in our division. So the goal is to understand disease severity, and we have used over the years a number of genetic mapping studies in rodents, gene expression studies using synovial fibroblasts, synovial tissues and other cells from rodents and patients. And then our discoveries are typically confirming synovial fibroblast studies using RA synovial fibroblasts. We validate those discoveries in rodent models of arthritis in human cells, and then ultimately to try to identify, validate the target to generate a new treatment. And we have been doing that, targeting a different synovial fibroblast antigens. So specifically now, how did we get from that to magnesium? So magnesium started as a curiosity, I would say, in our laboratory. And we just continue to pursue the data, and that's kind of the issue of evidence-based research or practice of the medicine. Started with a hypothesis, and then we did pilot studies, and I'll take you through that, like how did we identify this? And obviously I'm trying to make this also educational for our residents. So magnesium has been used to treat preeclampsia for decades. I'm a rheumatologist, yes. So how does that connect, right? So years ago, reading papers on preeclampsia, I learned that preeclampsia is characterized by a microvascular disease of the placenta with increased expression of a number of pro-inflammatory mediators that are also increased in the synovial tissues of RA patients. I thought that was an interesting parallel. And then I found some literature that magnesium supplementation in short-term in vitro studies interfere with several aspects of the immune response, like IL-6, IL-8, TNF, VEGF expression, which are all upregulated in synovial tissue of RA, as well as an FKB, which is also activated in increased level in RA patients. And we saw that in macrophages, it was reported in macrophages, endothelial cells, and placenta. I'm sorry, you're hearing our fire alarm. That happens twice a week, unfortunately, and we haven't been able to solve. So I hope you can continue to hear me well. And I'll try to remain focused. There was also some short-term magnesium supplementation studies in LPS-induced models that showed a benefit. So suggested that there was not only in vitro, but in vivo as well, some effect of magnesium supplementation in regulating immune response. So given that RA has a genetic component, but also environmental component, and then so we decided to look into could magnesium deficiency be yet another risk factor of having the genetic background, and then changes in how, or events on how the TCR, the T cell and the B cell repertoire develop, infections throughout your life, smoking. Perhaps a low magnesium diet could be yet another risk factor to tip off the balance towards developing disease. So we went and read and found that the US diet is typically deficient in magnesium. And you might ask, what are the magnesium rich, what is in the magnesium rich diet? So green leafy vegetables such as spinach, nuts, seeds, whole grains, etc. And actually there have been studies looking at magnesium levels in the general population, and 23% of the population has low levels of low serum levels of magnesium. Most of the magnesium is actually intracellular, so the serum level doesn't necessarily represent storages, but it's certainly an interesting and unexpected clue. If it's low inside, you have to move from the intracellular to the extracellular to compensate. So the hypothesis when we started this was that magnesium supplementation might be a simple and inexpensive, safe way of suppressing key inflammatory pathways to reduce arthritis severity. So the first study that we did a few years ago was actually using rat models of arthritis in a model called pristine-induced arthritis, that we inject this oil intradermally, and in 14 days, we inject at day 0, and in 14 days, the animals develop arthritis, and we follow them for 40 days. So before the induction of arthritis, we put the animals into either a low magnesium diet, a normal magnesium diet, or a magnesium supplemented diet. Oh, actually, let me tell you that not a magnesium supplemented diet, was a magnesium chloride supplementation in the water at that time. And then we stopped the diet around the time of arthritis onset. a low magnesium diet, animals had reduction in their serum levels of magnesium, as shown here. And unexpectedly, what we found at that time is that, well, the magnesium supplementation did not really affect arthritis severity and did not affect serum levels of magnesium, but the low magnesium diet animals there had a significant protection. It was a 70% protection in arthritis severity. And we repeated this study and confirmed that it was actually true. And here just showing you like an animal with arthritis developed this massive swelling of the ankle and some of the digits, while the animal on the low magnesium diet was significantly protected. Histologically, we were also able to see that the normal magnesium diet had pronounced hyperplasia, invasion and destruction of bone and cartilage, right? While the low magnesium diet really retained a normal joint architecture. So then we switched our studies to mice to further explore there and characterize what was going on. And we did a significantly larger number of animals. And what we saw in mice, so we first did this KRN serum-induced arthritis, where we induced arthritis with an arthritogenic serum that we breed in the laboratory. So basically, the animals get like 2 injections of this arthritogenic serum, and then by day 3 to 5, they start developing arthritis. So it's a very acute onset, severe disease. And we gave the animals either the low magnesium diet for a short period of time, as they didn't tolerate the diet for any longer, versus a normal diet, shown here in blue. And in green, the animals received this now a dietary supplement of magnesium, not just in water. So it was really more consistent, and probably we don't know in terms of absorption, that versus magnesium chloride, but it was persistent throughout, was given throughout the experiment. And what we were able to see is that both the low and the high magnesium diets significantly reduced disease severity. This may not look like a lot to you, but let me just tell you that very few things actually ameliorate this model. It's a very severe type of model. So this was very significant to us. And histologically, you could see that the animals that got the normal magnesium diet, which here is called MAG 500, had a lot of synovial hyperplasia and joint destruction, while the animals that got both the low and the high magnesium diet really retained normal joint architecture. The joints, the synovial membrane, the cartilage, the bone all looked normal. And Teresa quantified, Dr. Lillian quantified all of this. Oops, sorry about that. And confirm that particularly in the high magnesium diet, but there was a reduction in inflammation, reduction in hyperplasia, although only significant in the low mag diet here, reduction in erosion of both cartilage and bone. So we next looked at another and more well-established model of rheumatoid arthritis, which is collagen-induced arthritis. This is a more chronic type of model, not such acute, short duration model. And again, we gave the diet before the induction of disease, and then induced disease at day 0. They get a booster around day 21. And then we were able to see that, again, the 2 diets significantly protected the animals over time. So this is, again, arthritis severity over time. And again, histologically, even though they as the treatments, let's say as the disease evolved and got farther away from the end of the diet, you could see that the protection kind of disappeared. But that magnitude of protection could be observed also in late histologies of the pus collected at day 71, where you see the normal diet. The normal magnesium diet had a lot of synovial hyperplasia and erosion here on bone and cartilage, while the low and high magnesium diets, again, retain a normal joint architecture, despite at the later stage having some degree of inflammation. So to try to understand what was happening there, we examined the spleens of those animals and found that, again, the 2 diets in the KRN, the serum-induced arthritis that I told you, like the short-term severe disease, we were able to detect that the diets reduced levels of IL-1, reduced levels of IL-6, and reduced levels of TNF-alpha, as well as CXCL10, which is another important mediator of arthritis. And at the same time, increased levels of IL-10, which has been shown to suppress aspects of arthritis. And we were also both on day 6 and to some extent on day 15 as well as a later stage. We then examined like cellularity of the spleens of those animals. So we found that it reduced arthritis, protected the joint, reduced the expression of a number of pro-inflammatory mediators, increased the expression of an anti-inflammatory cytokine. And then we looked at cellularity in the spleens and found that the magnesium treated diet, particularly the supplemented magnesium supplemented diet group, had reduced levels of or numbers of Th17 T cells, both in the KRN, serum-induced arthritis, and in both models of arthritis. Also, the total number of IL-17 producing T cells was also reduced in the high magnesium diet and low magnesium diet. And one thing we didn't expect that was very interesting to discover was that both diets increased the number of FOXP3 positive Tregs. So Tregs is a T cell subset that's been shown to suppress a number of inflammatory and autoimmune responses. And so we saw that at an early time point, at a late time point. To some extent, we also saw that in collagen-induced arthritis, although we only looked at a very late time point in collagen-induced arthritis. And again, like we saw with IL-10 expression, we saw an increased number of IL-10 producing T cells. So with those observations, it was difficult to make sense initially. So how come that the low and the high magnesium diets could have the same effect, right? So a number of magnesium channels have intracellular signaling motifs. So what we initially thought was that changing the serum concentration of magnesium, or the environmental concentration of magnesium, might lead to a magnesium channel activation and then some similar intracellular event. So just the fluctuation of serum levels will lead to an activation of the channel. So we thought, well, let's examine that in vitro in different differentiating conditions and see if that really pans out. So we studied naive CD4 T cells in different differentiating conditions towards either Th17, T follicular helper cells, Tregs, and TR1, which is a T cell subset that produces a lot of IL-10 and it's been shown to have suppressive activity in a number of autoimmune events. And then we did this differentiation in different magnesium concentrations, and we did not see any difference. There was no clear difference in terms of having high, normal, or low concentrations of magnesium and the differentiation of those cells. So given the lack of a direct effect, so how could one explain this? So it could certainly be mediated by yet another cell, right? It could be that the magnesium could be affecting a cell that then drives T cell differentiation. We have previously looked at macrophages and did not really see a clear difference. And since the magnesium diet obviously has been given orally, so the next question was really, could this be mediated by the intestinal microbiome? And in a very preliminary study, we looked at different bacteria, at the beginning of the diet, and then at the end of the diet with magnesium, and then observed that while the normal bacteria, the normal magnesium diet kind of levels of certain bacteria remain unchanged, in the low and high magnesium diet, certain bacteria were reduced in frequency while others were increased. So that suggests that maybe there was something to it and was worth exploring. To really confirm that so for us, the critical issue is like not just what's magnesium doing to the microbiome, but does that mediate arthritis? Does that mediate arthritis and the effects on the Treg cells? So we set up a fecal material transplant where we collected feces from the animals that received one of the 3 diets, right? And then in a separate set of animals, we treated them with antibiotics for 5 days. After 5 days, for the following 5 days, they received daily gavage with fecal material from animals that had received one of the 3 diets. And then we induced this serum-induced arthritis and then collected stools at the end for exam. And what we found was that, so the antibiotic, the fecal material transfer, and again, arthritis severity over time. And here's the induction of arthritis. So what we found was that the animals that received fecal material transplant from the group that had received the low or the high magnesium diet were significantly protected. And actually this curve, if you remember, is very similar to the first one that I showed you in the first arthritis experiment. So that told us that this effect was at least in part significantly mediated by events taking place in the stools of those animals, right? And that's the microbiome. That also correlated with changes in histology. So again, here's the normal diet with this massive synovial hyperplasia, new angiogenesis, infiltration with leukocytes, while the high magnesium diet and the low magnesium diet retain a normal histology, as seen in the bottom here. So the 2 diets had reduced hyperplasia, reduced inflammation, a trend towards less erosion, but it's kind of like a short-term duration of disease. So there's probably not enough time to see any significant changes in this short period. We also examined the spleens of those animals and also found similar increases of FOXP3 positive Tregs in the high and the low magnesium diet, and an increased numbers of those IL-10 producing TR1 T cells based on those markers. So that was interesting. So we recreated the arthritis protection and the number of Tregs. So this, since it was mediated by fecal material transfer, right, and in a diet and related to a diet, so we decided to examine the intestines. We looked at the colon of those patients and stained for FOXP3. And here's the normal magnesium diet. You can see a few FOXP3 positive cells, not that many. But in the high magnesium diet, there is no doubt you have, at least to me, you have a number of positive cells all over. You also see it appears like an increased number of FOXP3 Tregs in the low magnesium diet, and Teresa quantified this, and while there seems to be a modest increase here, was really significant in the high magnesium diet. We also looked at small intestine staining for FOXP3 and did not really see a clear difference there. So next, with the help of the microbiome core facility here, we did a sequencing of fecal bacterial 16S ribosomal DNA, both of the high, low, and normal magnesium diet, and found several differences that I'll take you through. We found that depending on the diet, some Clostridium were increased, others were reduced. So there was a high degree of diversity that we were able to identify. So on the diet, right, so you could see that certain Clostridia seem to be reduced by the present reduced levels according to the diet. While in the fecal material transplant, some of those were actually variably increased, right? There was significant difference from one strain, one type of bacteria to the other. I will not take you through all the details here, but we'll focus on a few if I can move forward. Okay. When we looked at I'll focus here more on the fecal material transfer because to simplify this presentation. But this figure shows you the relative abundance of different strains of different types of bacteria. So you can see before the treatment with antibiotic treatment, those animals had similar bacterial representation. After the antibiotic treatment, basically most of the bacteria seem to disappear, right? And the diversity went down significantly. After the repopulation, so after 12 days, right, there is an increased diversity, but it's clearly not, if you look at the colors, it's clearly not exactly like it was in the beginning. So they were repopulated with the donor feces, right? And the panel C shows the comparison between the 3 treatments. And I'll just take you through the most relevant things. So in blue, you see what was upregulated in the animals that received normal magnesium diet. And you can see Prevotella marked in blue. The low magnesium diet, there were several that were present in increased numbers. And in the high magnesium diet, among several others, there was bacteroides. And here just to highlight Prevotella and bacteroides, because Prevotella, as I mentioned in the beginning, has been strongly associated with risk for RA, and it was had increased representation in the normal magnesium diet. And bacteroides has been shown to be reduced in RA. And here we found that the high magnesium diet was able to kind of shift this balance. And here just showing that, the bacteroides, so all the bacteria kind of seem to go down after, so before repopulation, after antibiotic treatment, and then after repopulation kind of goes back up. And depending on the bacteria, you see like here, there was an increase in bacteroides, while only the Prevotella of the examples that I'm showing you today remained significantly increased in the normal magnesium diet. SFB, which we initially studied because it's been correlated with Th17 expression, we did not really see, well, we saw a difference in Th17 expression and number of Th17 T cells. We did not really see a difference mediated by the diet on SFB, the segmented filamentous bacteria. So as I was telling, the Prevotella story that's been shown to be expanded in RA in at least 3 different studies. So how do we put together these differences? There are different bacteria, so there was not a uniformity between the bacteria that were represented at increased levels in the low magnesium diet and in the high magnesium diet. Yet both were protected. So it's difficult to put that into a context. So when we read about all those different bacteria, we found that they did have a few things in common. So in the fecal material transfer, we saw this overrepresentation in the high magnesium diet of several bacteria that have been associated with increased production of short-chain fatty acids. Short-chain fatty acids are metabolites typically from our fiber, and the bacteria metabolize fiber and generate short-chain fatty acids. And those have been shown to drive Treg differentiation in the intestines. While Prevotella is known to be a low producer of short-chain fatty acid. In fact, when there's experiments where people gave Prevotella to animals and found that it was able to drive a Th17 and IL-6 response and exacerbate experimental models of arthritis. And there was another bacteria, Bifidobacterium, that we found also expanded in the fecal material transfer recipients from high magnesium diet, has been implicated in TR1 differentiation, which to us was interesting as we saw an overrepresentation of TR1 in the high magnesium diet. In the animals that received the diets, actually the bacterial representation was different than those in the fecal material transfer, which to us was kind of intriguing. But one thing to keep in mind is the duration of the repopulation. So one thing are animals that have grown with a certain kind of bacterial repertoire. And after you wipe that out with antibiotics and only allow for a few days for recovery, it's been shown by other investigators that you never recover to what it was before, and is typically not exactly what was in the donors, and mostly because of this new environment, where you don't have other bacteria. So in different durations of you outgrow different strains. But what we saw similar was also that the bacteria present there were also a high producer of short chain fatty acids. Another thing that we did was what's called metagenomic analysis. So you can try to understand what are those bacteria doing by studying the metabolome of the fecal material, or you can infer changes by analyzing the bacteria that were differentially represented there and look at available data of what they are known to do. So, so basically there are databases, there are algorithms, there are softwares that do that for us. And we identified 25 different pathways that were differentially represented by this metagenomic analysis. Most of them were not obvious in terms of associating with either rheumatoid arthritis or changes in the microbiome or changes in Tregs numbers. Two were actually interesting. And I would say that the others just merit further study. It could be that there are new pathways that were not known before that we have to study. But we found the super pathway of L-tryptophan biosynthesis, and catabolites of tryptophan has been able to activate this AHR receptor to suppress immune responses. They are able to modulate Treg differentiation, inhibit Th17 T cells, and regulate models of multiple sclerosis, in addition to reducing levels of Prevotella. So again, like kind of fitting what we were observing. And Menin degradation pathway was also found to be differentially represented, and that has been known to activate the immune system, including complement neutrophils, which are two central components of arthritis pathogenesis. So in addition to short chain fatty acids that we talked about in my microbiome, there are several other factors that have been shown to influence, not shown by us, but in the literature. And for example, high salt concentrations have also been shown to increase levels of Prevotella and change this balance between Prevotella and lactobacillus, leading to reduced tryptophan and reduced short chain fatty acids. So it appears that our magnesium diet may have had like an effect very similar to this. And this has been shown to affect models of multiple sclerosis. So I tried to put together a kind of a combined slide of what's known in terms of microbiome and immune responses in a very, I would say, superficial way. And there's a lot more that could be added, but I think it's kind of didactic. So there are clearly now known genetic factors that regulate the intestinal microbiome, dietary factors like infections that we are exposed to, drugs that may affect, not just antibiotics, but a number of drugs that even aspartame seems to affect the microbiome, hormonal aspects. And that would then affect the prevalence or the frequency of Prevotella copri, right? And the number of short chain fatty acids. And that is known to interfere with autoreactive T cells, Tregs, to regulate diabetes, rheumatoid arthritis, and other autoimmune diseases, right? And even including multiple sclerosis. I would add to this the high salt that's been described by others, and L-tryptophan as two other factors that affect the microbiome. And our observation here that the dietary magnesium can potentially affect tryptophan. So in two ways affecting the microbiome, but also could be used as a future drug, as a supplementation. And we are actually trying to do that in a trial with rheumatoid arthritis. And we have a protocol that's being reviewed by the COVID committee here and being considered to treat COVID, because as all of you know by now, so all the cytokines that we have found to be suppressed by magnesium are up in COVID, and severe COVID patients have been reported to have very low levels of Tregs. So that was a rationale to try to propose a benign and inexpensive way of treatment COVID with oral magnesium. So hopefully we'll be able to test that soon. So in summary, modifications in dietary magnesium can affect arthritis severity and joint damage, and we show that in at least 2 rodent models of arthritis. It changes pro-inflammatory cytokines, increases number of FOXP3 positive Tregs and the TR1 cells, both known to suppress autoimmune responses. The in vivo effects are mediated by changes in intestinal microbiome, and in our view, by favoring different strains that produce increased levels of short-chain fatty acid, among other changes that are open for discovery, I would say, at this point. And magnesium reduced levels of Prevotella, and this balance between Prevotella, Clostridium, and Bacteroides. And this has been associated with RA. So to our knowledge, I'm not aware of another strategy so far that has been shown to be able to change this balance. So it's such a benign thing that I think merits further study. And that's what we're trying to do with rheumatoid arthritis, see if we can, by giving oral magnesium, affect disease severity, increase number of Tregs while modulating this Prevotella balance. So we see there's a potential to become a new adjuvant for treatment in the future. I have to, is medicine, right? Grand rounds from it. So reminding you guys, eat your vegetables, right? Whole grains and nuts. And as I said, we're currently working on a trial of magnesium supplementation in RA and in severe COVID. And most of this work was done by Teresa Laragione, who is here joining us today, and Caroline Harris in my lab. She's on vacation now. And then Daniel's on vacation. Nassim left. She's in medical school. Other former members of the lab. Gerardo's Bongers from the Sina Microbiome Core Facility was fantastic. Did a lot of work. Went way beyond what the core facility would typically do, and has become our valued collaborator in this study. Over the years, Christine Beaton has been our collaborator in ion channel related matters. And we use synovial tissues from the Feinstein, so we have other collaborations that don't apply here. And this work has all been funded by NIAMS and the National Institute of Health with some help from Mount Sinai. Thank you. Happy to answer any questions.
Great, thanks, Percio. There's a couple questions in the chat.
Okay.
Already.
Oh, okay. Is there another disease ameliorated by both high and low magnesium? If so, is there any common factors between the diseases and the immune system? So there is a recent study that actually used magnesium supplementation. The low magnesium diet, put the chat here so I look at you. So the low magnesium diet we use more as a proof of concept. Because in the beginning, we thought that the low magnesium diet would just exacerbate disease. So it's always like a proof of concept idea that turned out to have a meaningful phenotype. But we don't think it'll be like a strategy to be used because of the mice didn't tolerate a low magnesium diet, and then there is risk of bone loss, there is risk of arrhythmias and so forth. And a low magnesium diet is just not palatable. But we are aware of a high magnesium diet that was actually just recently published in a DSS-induced colitis model. So in colitis, it has been tried. and we're actually now in the process of studying that to see whether in colitis we also see changes in FOXP3 Tregs. That's what I was telling Bruce. Now we're venturing in the IBD world. Thanks for the amazing talk. Now I know what to do with magnesium. So, okay, so Sakshi, the magnesium supplements, so we want to examine, so that was Sakshi Dua's question. So Sakshi, we want to examine that exactly. So the issue is that we, it's very benign, but we haven't really shown in humans yet, right? So we're trying to get the trial going, but as a trial, the FDA, even though it's a supplement, it's over the counter, the FDA still wants us to get like an IND, and we'll have to commit with, I guess, a manufacturer to have everything described to them. The other thing that I have noticed, Sakshi, is that there is great variability from one magnesium formulation to another. There is literature showing that citrate oxide and others have similar absorption. But like I tell everyone here in rheumatology, prior to planning this trial, I bought several different over-the-counter magnesium preparations just to get a sense of tolerability. And I got to tell, there is tremendous variability from one formulation to the other. Not all are well tolerated. So Eileen, Cecilia, Tregs are important in suppressing graft versus host disease without suppressing graft versus tumor disease. I can't seem to find anything about modulating magnesium diet. I'm not aware either of magnesium. So that's one of the things that we are interested in exploring in terms of different aspects of, so this is Eileen Sigliano, that we're very interested in exploring other aspects of how this simple, inexpensive, and safe strategy could help control diseases, being IBD, graft versus host, arthritis. So Eileen, if you work with graft versus host models, contact me afterwards, and we can plan to do this together, or we can help you. Mark Horowitz, what dose of magnesium do you recommend? That's a tough one. So Mark, I don't know, because remember that the mouse and rat requirements of magnesium are different from ours, right? And in our case, in humans, there is also the tolerability aspect. So basically, in the trials, we'll have to find out in the trials, or in the proposed trials, again, making clear that it has not been tested. We were planning to test 400 a day versus 800 milligrams of magnesium a day, either oxide or citrate. But again, it has not been tested, so I'm not really prescribing that to my patients. A quick search shows, I don't know if that's how you usually do. I'm just reading the questions and trying to. A quick search shows a study from Haynes showing moderate magnesium in the diet to have the lowest rates of arthritis. Is there any other real world data of dietary magnesium? I don't know. I don't know if this study, so there was a study that we discovered this actually just maybe a month or so ago, that used the CDC database of dietary. There was this huge CDC database with thousands of Americans and dietary habits. And there was a study that retrospectively looked at that and dietary changes in RA susceptibility. It was, I don't remember what was their finding. I remember they found with the low and the high magnesium diet an RA effect, but it was not clear that there was. I'll have to look back. I don't remember that now. How to handle a low magnesium found on routine testing and also high magnesium. Oh, okay. Well, that's so that's kind of a, so I don't typically manage magnesium, right? So the serum magnesium in the person with normal kidney function, right? And even moderate renal insufficiency, that person can easily handle magnesium supplementation without any problems. Low magnesium diet, low magnesium in serum levels, it's a difficult one to really address because, as I said, most of the magnesium is intracellular. So extracellular levels are not necessary, have not, to my knowledge, necessarily predict this disease, right? So obviously, if your patient is on digoxin, if anyone still uses digoxin, right, or has a bone disease, or a history of arrhythmia, or a patient is in the hospital, I will certainly treat. But the management of an isolated, asymptomatic, single test of single low magnesium level, I'm not sure would necessarily require treatment. I think that would have to be individualized. John, there is a close interaction between magnesium, vitamin D, and vitamin D has anti-inflammatory. This might be another, definitely no. And magnesium and calcium inside the cell, they work kind of as competitors, right? So we did not look for any interaction with magnesium, vitamin D, but definitely, it could be two different ways to try to minimize or to affect the severity. Low levels of vitamin D have not been associated with risk with RA, but within the RA population, low levels of vitamin D seem to correlate with more severe disease. Right? But yes, thank you for the suggestion. What about magnesium malate? So I don't know. We have not tried that. In terms of absorption, I remember there was a study that compared oral absorption of several formulations of magnesium. I remember citrate, oxide. I don't remember all of them. I remember malate was also tested there. So I don't know.
Percio, one last question. It seems that just have come to me. The question is, zinc is a potent anti-inflammatory. Do you have any experience using zinc or a combination of zinc and magnesium with RA?
No, and I'm not aware of zinc being this. Zinc is thought to be an anti-inflammatory, right? Not sure how much it has actually been shown to work as an anti-inflammatory in human diseases, right? So like, I think it was like zinc lozenges that were shown like 20 years ago to reduce the duration of flu or cold by 1 day, and that was it, right? That's my record. So I'm not sure if there are trials. Well, there has been some suggestion like being an antioxidant and having an anti-inflammatory, but I'm not sure if there has been validated in human studies. There are reasons to have now I'm totally out of rheumatology, right? I become like a dietary advisor, right? And during this talk. But
I'm sure your kids are eating all their vegetables, Percio.
Yeah, I try.
I'm sure. Well, listen, I want to thank you for spending the day. This was really great to have you show the work that you're doing for us in rheumatology. So congratulations on that. So thanks, everyone. Have a great day. And thanks for coming to Grand Round. See you all soon. Take it easy.
Thank you.
Thanks.
Thanks for having me.